Welcome to part 1 of our complete 15-part breast surgery coding masterclass explainer. Today, we're bridging that massive gap between complex clinical biology and picking the exact right CPT code. Look, if you're a medical coder, maybe a CPC, CIRC, or CCS aspirant, or a clinical documentation specialist, you already know that translating dense operative reports into accurate codes is practically an art form. You absolutely can't just stare at the CPT book and hope for the best. You really have to understand the anatomy and the pathophysiology driving the surgeon's hands.
All right, let's take a quick look at our masterclass syllabus for today. We're laying down a rock-solid foundation, so we'll be covering surgical anatomy for coders, axillary lymph node basins, a clinical pathophysiology overview, and finally, translating terminology to CPT. Starting right off with Section 1, Surgical Anatomy for Coders, taking us beyond just the biology.
Listen, we aren't just learning anatomy so we can perform the surgery. We're learning it so we can decode the surgery. Literally every single anatomical term a surgeon dictates is going to impact your code selection and your modifiers. So let's visualize this. The breasts are paired structures sitting on the anterior thoracic wall, right over that pectoralis major muscle. They're packed with glandular tissue, supported by Cooper's ligaments, covered in a layer of fatty tissue, and they all culminate in the central nipple areolar complex, or NAC. Now, pay special attention to the axillary tail of Spence. While the circular body is obviously the most prominent part, this little tail runs right along the inferior lateral edge and stretches into the axillary fossa. Knowing about this tail is a total game changer, because it explains why certain procedures have to extend so deep into the underarm area.
Think of the breast like a giant clock face. It's mapped out into 4 distinct quadrants: upper inner, upper outer, lower inner, and lower outer, plus that central subareolar portion. This is incredibly important because a tumor's exact location is almost always dictated as a time on a clock. That clinical orientation directly dictates your parent code and your modifier selection. So when you're reading an op report and you see 2 o'clock or 7 o'clock, you should instantly know exactly which quadrant that surgeon is working in. Moving a bit deeper here, each breast is heavily supplied with blood and lymph vessels. As lymphatic vessels carry fluid away, they usually hit a sentinel node first. Think of the sentinel node as the very first line of defense. It's the first lymph node that cancer cells are most likely to spread to from a primary tumor. And hey, sometimes there can actually be more than one. This is exactly why you'll constantly see surgeons injecting radioactive dyes to literally trace this pathway before they start making larger excisions.
Moving right along to Section 2, Axillary lymph node basins, and how to navigate those levels.
Okay, so let's see how this lymphatic drainage builds into the axillary lymph node basins. I'm not going to lie, this is where coding can get extremely tricky if you lose track of your surgical landmarks. There are 3 levels of axillary lymph nodes in the underarm, and they're all mapped relative to one specific anchor point, the pectoralis minor muscle. If you get your levels mixed up, those NCCI edits or paired denoyals are going to hit you hard. Just remember this simple mapping. Level I is inferior, meaning below the lower edge of the pectoralis minor. Level 2 is deep, right underneath the muscle, and level 3 is superior, or above it. So here's a massive coding alert for you. You absolutely must look for very specific documentation to get this right. Let's take CPT 38525 for open, deep axillary nodes, levels 2 and 3. They are always considered deep. But level 1 nodes out in the lateral part of the armpit, those could be superficial or they could be deep. It totally depends on the patient. Because of that, you strictly need the doctor to document the location and depth relative to the fascia to report 38525 accurately. Oh, and quick side note, lymph nodes aren't paired organs, so they don't inherently need a laterality modifier, but, always follow your specific payer guidance on that one.
That brings us to Section 3, Clinical Pathophysiology Overview, looking closely at benign versus malignant indications. Now it's time to put on your investigator hat. We have to use the clinical indications to justify the medical necessity of whatever procedure was done. Generally, breast disorders are going to fall into 2 main buckets, benign or malignant. On the benign side, you've got fluid-filled cysts, solid fibroadenomas, and those wart-like intraductal papillomas. But you have to contrast those sharply with neoplasms and malignancies, where you'll be scanning the report for heavy-hitter terminology like DCIS, ductal carcinoma in situ, or invasive ductal carcinoma.
But wait, there's a bit more you need to keep an eye out for. Things like hyperplasia, which is a cellular overgrowth linked to higher cancer risks. You might also run into painful mastitis, which is basically inflammation usually paired with an infection, or gynecomastia, the enlargement of male breast gland tissue. And of course, you might be coding for surgical complications like a ruptured implant or post-op bleeding.
Nailing down the exact pathology from the start completely dictates which coding pathway you're going to take. All right, home stretch, section 4, translating terminology to CPT. Let's get into the coder's key takeaways. This is where the rubber really meets the road. We're going to take all that foundational knowledge and apply it to actual op report terminology. Let's kick it off with localization devices. We're talking clips, metallic pellets, or radioactive seeds placed percutaneously under imaging guidance. Here is the golden rule, guys. Always report your localization device codes based on the number of lesions. Do not code based on the number of devices placed. Why? Because a single large lesion might actually need multiple devices to mark it properly. If a device goes into 2 completely distinct lesions, you'd code a primary CPT and an add-on code for that additional lesion, even if they're on opposite breasts. When it comes to excisions, precision is absolutely everything. You've got CPT 1911-12, which covers the full removal of a lactiferous duct fistula. A fistula is just an abnormal tract between the skin and the duct, right? Well, this code is comprehensive. It includes excising the duct, the fistula itself, and the skin opening. On the flip side, CPT 1920 is your classic go-to code for the excision of a cyst, a fibroadenoma, or a tumor, as long as it's done without a preoperative radiological marker. Now let's scale things up a bit to mastectomies, specifically CPT 19307, the modified radical mastectomy. This code bundles in the axillary lymph nodes. The breast tissue and skin are meticulously dissected from the pectoral fascia, and then both the breast and axillary tissue are removed en bloc, meaning all together in one piece. But here is your anchor point for this specific code. The operative note might say the pectoralis minor muscle was resected to help with the axillary dissection, but the pectoralis major muscle absolutely must be left intact. If the surgeon takes that major muscle, you are suddenly looking at a completely different family of codes. To put that into perspective, check out this actual snippet from an op report. The surgeon dictates, the breast tissue along with the pectoralis major fascia were dissected off the pectoralis major muscle. The breast was removed, and then the axillary contents were dissected out. Later in the note, they also mention that the patient had clinically palpable lymph nodes, which were taken out during that axillary dissection. So based on all the groundwork we just laid down, what code does this justify? Does this sound like just a simple excision to you? Or does the en bloc removal of the axillary contents, combined with the deliberate sparing of that major muscle, point you straight to our modified radical mastectomy code? Think about it. The clinical anatomy we talked about earlier, like the fascia, the axillary contents, the major muscle, those are the exact breadcrumbs you need to confidently lock in code 19307. We've built a really solid foundation today, but we are just getting started. In Part 2, we are going to dive headfirst into the often confusing world of laterality modifiers, breaking down exactly when you should be reaching for LT, RT, 50, 59, and XE. Thank you for watching, keep coding with confidence, and make sure to subscribe to Decode Healthcare with Harshal. See you in Part 2.